Hi, I'm Brian Levy. I am the Chief Relationship Officer at Manchester Living and the host of the Manchester Living podcast. The purpose of the podcast is to help people navigate the complex maze of elder care. There is a lexicon of elder care terms on the website at manchesterlivingpodcast.com. Today's episode is titled, Don't Let Hospice Be the H Word. But first, new and noteworthy. A very good friend of mine lost her battle with breast cancer years ago. May she rest in peace. She often commented that dying was a full-time job. She found a reason to laugh every single day, and it helped her through the dying process, as humor helps us all through difficult situations. We'll roll the clip.
Hi, Brenda with the Hospice Care Plan, and I want to talk about humor at end of life, or humor in general. We hospice nurses, we like to think we're a pretty funny bunch. I don't know how accurate that is, but we like to think that. But what we really do know is the value of humor and all the things that happen in our body and our soul when we're able to laugh with somebody. And whether it's a stranger or somebody you're very close with, when you can really laugh together, it is healing, it's good. And I think for myself, my humor tends to be a little dark, a little sarcastic, so I have to be careful with that. And also it depends on how well I know somebody. I think most hospice workers who are seasoned, they can't be shocked by anything that anybody says. And I really encourage humor in families. I'm going to give a couple examples. Sometimes when the situation is just heavy and we've talked about dying just a lot. And I'll say, what do I do? And I'll just say, you know what? Why don't you just take a break from dying today and do something fun? And it usually creates a chuckle, but it also gives some perspective that just your time is short. You're dying. You do have to take a break from it.
Humor, the gift that keeps on giving. I have my friends Aqua and Rochelle on the show today. Rochelle Brozgold-Ready. She is the neuro-oncology social worker at UT Southwestern in Dallas, Texas. And Aqua Umoren is the owner of Holding Hands Hospice. Welcome. Thank you both for being here.
Thank you.
Aqua, who are you and what do you do?
Well, I'm a person.
Thank you.
But I own and operate a community-based hospice agency here in Dallas.
Great. Rochelle, who are you and what do you do?
I am an oncology social worker. I've been a social worker for a very long time. But I've been at UT Southwestern for the last 15 years, and I work in the Simmons Comprehensive Cancer Center.
Wonderful. I think I have some qualified guests on the show today. Thanks for being here.
Absolutely.
In the intro, I mentioned the dying process and how difficult it can be. Do you want to just talk broadly about that, Aqua?
Well, the dying process is an individualized process for each person that has to go through it. Some folks, the dying process is something that happens rapidly. And then some folks, it's something that could last 1, 2, 3, 4 years, depending on what is causing them to start that type of decline.
Do certain age groups die faster? Certain diagnoses take longer? Does it have anything to do with age and diagnosis, or is it just personal?
Yeah, it's probably more to do with diagnosis. And then secondary would be age. Someone who's a little bit younger is probably able to handle something like cancer and the cancer treatments differently than someone who's 84 years old who's trying to go through those same type of treatments. Their body is just not in the condition it would need to be in order to withstand some of the different types of treatments that they would be taking.
Sure. And the process starts differently. I know with my friend, you get a diagnosis and, she always said it was a full-time job, and that entailed everything from doctor appointments to, medication management. It's a full-time job to die. And then you get somebody who has a full diagnosis and they're farther along, they're bedridden or, terminal in a situation. That's a different kind of process.
Yeah. The dying process is 7 days a week. 24/7. And it's very similar to when you birth a baby. That process is 24 hours a day, 7 days a week. Same thing applies for when someone is starting that transitional process.
And both take it's nature.
Yeah.
Yeah. Great. Rochelle, how do you coach a family or friends who don't know what to say when broaching the subject of hospice? How do you even start that conversation?
So that takes place in a variety of different situations. For myself, working in an oncology outpatient clinic, I have to wait for our oncologist to tell me that it's time to have that conversation with the patient and family. It usually happens during their clinic visit. And I'm asked to go in and visit with them in person, which I would much rather visit with them in person than to have that conversation on the phone.
Sure.
So I have to go in and kind of read the room and see if the patient and or the family appears to be willing to have that conversation.
Is the patient always in that meeting?
The patient in the clinic, the patient is always in that meeting because it's during one of their clinic visits. So when I walk in and introduce myself, I immediately look at the patient, talk to the family. If the patient is unable to have a conversation with me, I then direct my attention to the family members and say, because they've just gotten the news that hospice is now appropriate based on, progression of disease or, failure to benefit from further treatment. So a lot of times they're hit with that and it's not a good time to even have the conversation. It's just too much to take in at one time.
Yeah.
And so if they're not ready to have that conversation, I'll tell them I would call them and, we'll schedule another time to meet. If they are ready to have the conversation, then we just sit down and start having the conversation. And I provide them education, information, what is hospice, kind of dispel their fears, talk about how hospice is a good thing for people at the end of life, that it actually helps them feel better at the end of their life. Patients can actually live longer on hospice once they've been placed on hospice because their symptoms are being managed. They're not coming back and forth to the clinic anymore. Mm-hmm. They're not receiving MRIs and labs and having to go back and forth. So they're more comfortable.
We titled the show the H word. We were joking before the show. It's this isn't your father's Oldsmobile. This isn't the hospice that our parents grew up with. Mm-hmm. Can you elaborate, both of you guys, elaborate on that and talk about the difference of where we are today with hospice compared to where we came from?
Well, I can only go back so far.
Right, because you're only 32.
31.
Yeah,
no.
Right.
But I think our grandparents' iteration of hospice was something that came into place when you were a few days out from actually making that transition. And when you spin that forward to where we are now in 2024, the definition of hospice has expanded probably 10 times what it was maybe 50 or 60 years ago. So like an individual can be on hospice due to their qualifying diagnosis, but that doesn't necessarily mean that they're going to pass tomorrow mm-hmm. or even pass in a week or even in a year. So for sure, nowadays with with medicine being done better, with caregiving being more of an accessed resource, like this great company called Cambridge Caregivers does really, really well with providing in-home care. But, everything's gotten better. And so the result of that is people are living longer, mm-hmm. even with terminal diagnoses like cancer or congestive heart failure or dementia or Alzheimer's.
Mm-hmm. Great. Aqua, can you speak to, on past episodes, I've talked about palliative care in comparison to hospice. Do you want to just briefly talk about the two and then define each, please?
Yeah. So when folks go on palliative care, they are managing a symptom that needs to be controlled. So you can think pain management, or a person's riddled with anxiety, or maybe they have, acute nausea due to some of the radiation and chemotherapy treatments that they're getting. So palliative care is going to manage just the symptom while giving you a window or a door to say, hey, I still want to go get treatment for whatever it is that's causing you to have these symptoms. Hospice is total care. So not only does hospice manage the symptom part of it, but they also provide psychosocial resources like a social worker. They provide spiritual resources and support like a chaplain. They provide medications, obviously, to help manage some of the symptoms related to the diagnosis. And they provide, equipment, incontinence supplies. You have staff coming to the house. So it's a little bit more it's a little bit more inclusive than just saying specifically, hey, I'm going to manage this symptom that's related to this diagnosis while you go get treatment. Hospice is a little bit more, it offers a little bit more from a service delivery standpoint.
Got it. And how does one qualify for hospice?
Well, now it's like looking at a painting and saying, hey, this is what I think the painting is saying. And then somebody else says, well, I think it says something different.
That was beautiful. It's like I'm on the Thomas Crown affair.
But technically, the way Medicare has set up their guidelines is that you have to have a diagnosis that gives you a expectancy of 6 months or less. So there are qualifying diagnoses, obviously like cancer, that you can be given, and that would make you qualified for the hospice benefit. But you have to be at a point where you're no longer seeking those types of treatments. You can't seek treatment, and I'm sure Rochelle will offer more on this.
Yeah.
But you can't continue to seek out aggressive interventions while being on hospice. Those two things are like oil and water. So, we're talking of things, maybe protein malnutrition, cancer, dementia, Alzheimer's, congestive heart failure, COPD, stroke. Those sorts of things are more in line with what CMS or Medicare views as diagnoses that will inevitably lead to you passing or transitioning, as I like to say. I think it's a more appropriate word.
Clinical. How does one qualify for hospice services?
Yes. Okay. So once it's deemed that treatment is no longer going to be sought for the patient, then it's time to have that conversation. Patients may not be ready to start care at that time, but that's the appropriate time to have the conversation, explain what hospice is, again, dispel any of the fears and the misnomers about hospice. I find a lot of times my patients think that hospice hastens death when it doesn't. It actually provides more care for the patient so that they actually they can live longer and have a better quality of life because their symptoms are being managed.
Right. So I talk about with our clients, when I'm talking about hospice, I talk about some of the benefits that they are no longer going to have to be responsible for, including the incontinence supplies, like you mentioned, the medicine, the hospital bed, things like that. That's my point to the family is you've been paying into the system this whole time. Now it's your turn to reap the benefits.
Yeah.
Also, on a more personal note, I am always very clear in telling, especially spouses, that you've been going through this caregiving experience for X number of months or years, and having to be the caregiver. Once hospice comes in, you don't have to be the caregiver anymore. You can be the husband. You can sit and hold your wife's hand. Right. You can spend time with her, whatever time you have left, and talk about the things that are important and have those lasting memories as her spouse or their spouse instead of being the caregiver. And you can just hear the relief.
I love that part.
They can hear the relief. They're
absolutely.
Like, that makes so much sense.
Thank you for that.
I would love that.
In addition to the things that we talked about that hospice provides, is there a 24-hour aid? Is there daily showers? Talk about Aqua. You want to?
Yeah. Allow me to elaborate on that. Please. Because that is probably the number one question I get on a daily basis is, hey, we want hospice, but what kind of coverage am I going to get? Meaning who's going to be coming out to my house and how frequently, how long are they going to stay? One of the misnomers with hospice is that most people think that they're going to get a 24-hour caregiver or a 24-hour nurse. And that's not the case, bottom line. When you are on hospice, we are here to help support, provide resources, and educate on what the disease process is going to be and what you can expect from 1 week to the next. But that does not translate over into 24-hour caregivers. Again, a great company, Cambridge Caregiving Agency, they provide the 24-hour care, but unfortunately, Medicare does not have the bandwidth to allow for agencies to provide that level of coverage. However, there is a point in that dying process where accessing that degree of caregiving coverage is possible, but we call that like crisis care. And
so towards the end of life.
Well, towards the end of life, and or if there's a crisis.
Got it.
And so, our goal going in from admission through discharge is to try to prevent that crisis from happening. It's actually not a good thing if a nurse has to sit there and medicate your family member every 1 or 2 hours, because that means something is way, way, way out of control. And our philosophy is, hey, if we make this person comfortable enough, that dying process should be a smooth transition. Now, there are situations that it can't be avoided. And yes, we have to bring in a 24-hour nurse or 24-hour caregiver. But typically, that's not something that your private insurance, managed insurance, and or Medicare provides coverage for.
What is the cost for hospice services? And I know Medicare covers hospice services. Can you private pay? Would there be a situation where you would have to private pay?
The only thing that you would have to private pay for regarding hospice are things that are not considered in like the hospice formulary. So let's say hospice provides a pull-up, and you're like, well, my mom likes to use this pull-up. We ordered it off of Amazon. Well, that might not be something that we can get. So that would be a situation where they could private pay. But outside of that, they shouldn't really be paying for anything that the hospice is doing. All of our services are covered 100% through Medicare. I've been doing this 10 years, and I've never billed someone directly for anything
Supplies.
For that matter. Yeah.
The three of us have been working together for about 8 years, and I know we talk about duration of life often. People don't like the unknown, and they want a timeline. They want answers. How do you address the duration with the life cycle question? How long am I going to be on hospice? When am I going to die? Rochelle?
So that's a very complicated question and answer. Every patient, as Aqua said, is different. Every diagnosis is different. People enter hospice at different stages of their dying process. So it's difficult to say. We don't have a magic ball, and we tell them that, but there are certain things you can look for, and Aqua can speak to that as well. But typically patients become more somnolent, they sleep more, they're awake less, they're eating less, and they may not talk as much. And so those are things that we tell them to look for, just so that they have some sort of a general idea.
Sure.
It doesn't mean it's going to happen that day or the next day. People can stay in that state for some time.
For years.
We've had people on hospice for 4 or 5 years. Yeah.
But to your point, Rochelle, of course, we get the question all the time, well, how long is mom going to live? And I'm like, that needs not to be your focus. Your focus needs to be the moment, because mom could go in 4 days or 4 months, but you have to stay in the moment and just appreciate what you have today. So I try to enjoy the moment that you have with them. So I try not to even get into those type of prediction type questions, because, when I first started, I was like, this person, they'll live for 90 days. And 2 years later, they're still living. And you're like, you told me they were going to live for 90 days,
right.
you know, or vice versa. You know, hey, this person looks really healthy. Yeah, they have a cancer diagnosis or some other diagnosis. You know, I could see them living for 6 months, and next day I get a phone call saying that they passed away. So
there's no predicting.
There's no predicting it. All you can do is try to prepare, educate, and give them some idea of what to expect, with the caveat of stay in the moment, be here now.
Mm-hmm. Great point. Mm-hmm. Along those lines, we've all heard families say, "Oh my gosh, mom looks miserable. I think I saw her wince. Speed up the process. Give her more morphine. Speed it up." How do you address that with families?
Yeah, we're not here to accelerate the dying process.
This isn't homicide.
This is not homicide, and we are not in Oregon.
Right, there you go.
Okay.
Yeah.
And so, you know, when someone says things like that to us, you know, we try to redirect and focus on, hey, okay, well, maybe we can adjust the pain medication a little bit. But, you know, right now, her or him approaching the point of where they pass, that's between them and whoever their higher power is.
So through the declining process, we talk about meeting them where they are.
Yeah.
That goes through end of life as well. And that's their journey and their process.
Yeah.
Yeah. When a family is unreasonable and they want a full code on a 98-year-old or a feeding tube on a 93-year-old, how do you address that? I know both of you guys have.
I mean, sometimes you have to physically show them what it means for someone to jump on their 98-year-old mother's chest and do chest compressions and what the subsequent result of that would be. And, you know, I feel like if you frame things in a quality of life standpoint, it gets them refocused. Mm-hmm. Okay, let's say your mom does pass, CPR is done, she's resuscitated, and now she's been without oxygen for, I don't know, a few minutes, whatever.
Yeah.
That's not going to be your mom.
And she has 6 broken ribs.
And she's got 10 broken ribs.
Yeah.
And in pain.
And she's in pain.
Right.
But your mom, physically, you'll see your mom, but mentally, your mom is already gone. Mm-hmm. So is that what you would want for one of your loved ones? And 10 times out of 10, it's no.
Right.
Mm-hmm.
And so that's how you kind of combat the full code as opposed to DNR, which is do not resuscitate, which only means, for just disclaimer, if a person is found unresponsive, they're not going to try any life-sustaining treatments.
Rochelle, what is the role for a social worker in a cancer center?
It's very broad. It's a very broad role. I'll just speak to my role specifically. Sure. So we provide education on, so everything we do is not hospice related. So if a patient is not ready for hospice, we also do provide education on things like home health care, rehabilitation, things that they can benefit from while they're still healthy enough and can get a little bit stronger. So we provide home health care assistance, outpatient rehab, inpatient rehab, ordering equipment, connecting families to other resources, and then just providing any type of education that they need. We do education. We provide education on disability, applying for disability, when people can no longer work.
You're really you are the resource center.
We kind of are the resource center. Yeah, we're kind of the jack of all trades.
Yeah, yeah.
But
that's why I got a thick Rolodex.
But to this conversation, we provide a lot of education on hospice before we even call the hospice agency, because I feel like it's our role to make sure that they understand what hospice is, and again, dispel those fears. I know the hospice agencies really appreciate it when we take the time as social workers to give them, it's kind of like an intro, we call it Hospice 101, answer all their questions, get them set up so that when the hospice agencies are ready to come and visit with them and do their meetings with them, they already have an idea of what to ask. And I also provide them with a checklist of questions to interview
Right.
hospice agencies with.
And then your role is also to refer them, that give them the resource, say, hey, call these 2 companies or these 4 companies, call Aqua, ask him a lot of questions, and then you come in and continue the education process. You're not in a sales role, you're just a resource.
Exactly.
I don't sell hospice.
Yeah.
My job is to provide information so folks can make a informed decision. But if you don't mind, let me step back. Rochelle is severely under, she is not giving full light to what her role does in that setting. Just think of if you are in a country you've never been to before, you have no maps, you have no idea of a sense of direction, and they tell you, hey, we want you to get to this restaurant. You need to be there in like 45 minutes. And you're like, well, I don't know, north, south, east. So the social worker in her setting is very similar to a legit GPS. They are literally telling these people, turn left here, go straight, turn right. Hey, you can continue to go the direction you're going in, but there's construction, there's an accident, there's potholes, there's all kinds of stuff that's going to cause you trials and tribulation. But if you want to go, you can go. But I would suggest going around all of that. So we rely heavily on the pre-education that occurs in the clinical settings like an oncology center, because, more times than not, when I am in front of a family, they don't know anything about hospice. They're like, okay, well, I didn't even know why you were here. I'm like, well, Mom.
She'll send me in.
No, you're right. And I pride myself on providing that education. And, and if nothing else, I hear from the hospice agencies how much they appreciate it. Because when your nurse goes in to have the hospice meeting with the family, they've already been prepped on what it is. I've answered as many questions as I can.
Right.
I've given them written information, and so we've had a full-on hospice conversation, and it makes it easier, I think, for them to then interview and make a decision on which hospice agency they want to choose.
Sure. And I think it's important to point out the importance of planning in advance. And I think we're so accustomed to operating in crisis mode that even if you're not ready for hospice, start that conversation, educate yourself, and know when you're ready, you're going to be ready, but don't do it at the 11th hour and make a mistake or not, so you don't have to cram.
Right. So to that point, I will say that we are really good at doing that and in helping our physicians see that the importance of having these conversations sooner than later is so beneficial, especially to the family members. During my education talks with them, one of the biggest things I try to get across to them is, I don't want to see you in a crisis. I don't want to see you in chaos. I don't want your loved one to be suffering. Those are the 3 things that I make a big point of. And they, of course, agree. Nobody wants any of that. Right. And so I encourage them to at least have the meetings, make your decision, and then put it in your back pocket.
Yeah.
And then you can, when the time comes and or you have a question, you think it might be time, then you make a phone call, to the physician. And if it's time, you just pull that out. You've already had your meeting. You know who's coming to the door. You know what to expect. Yeah. So the crisis is averted.
Aqua, to sign up for hospice services, whether you're ready to start tonight or in 2 weeks, what does that process look like?
Well, typically we'll be contacted by a physician office and saying, hey, we have this patient that has ABC wrong. We'd like to refer them to hospice. So they'll send over their information. Of course, they are already let the family know, hey, you're going to be contacted by a hospice agency. Once we get a history and physical progress note, a physician order that allows us to evaluate for appropriateness for the hospice program, demographics, which give us all the insurance information, date of birth, emergency contacts. Once we get all that information populated in our system, we contact the patient, we schedule a time. We'll go out there. It's about 10 pages of consent forms that a responsible hospice would be going through line by line and making sure that they fully understood what it is for them to put their loved one on hospice. Mm-hmm. And again, the biggest pushback question I get is, okay, well, we still think mom has hope, or, we mm-hmm. still think mom has a chance to get better. And I love to say this, hospice is not contractual. You're not signing a life contract to say, hey, I'm going to be on hospice for the rest of my life until I pass. Exactly. There are people who come on and off of hospice all the time. There is no time limit for the length of stay or time that you can be on the hospice benefit. It's in perpetuity. And you can come on and off whenever you want.
And talk about the process of if somebody's on service with a hospice company that they don't like for whatever reason, there's a service failure, things aren't going well. What is the process to stop that company and go to a holding hands or another hospice company?
Super simple. The only disclaimer is that you will be introduced to this thing called benefit periods. Okay. And when someone first comes on hospice, the first 2 benefit periods are 90 days apiece, right? 90, 180, 6 months. That's where the 6 months or less comes in when people are explaining what hospice is. The reason why I say that is transferring hospice agencies, you can only do once a benefit period. Okay. Transferring hospice agencies, you can only do once a benefit period. So if you're not happy with service delivery and you want to transfer and you just started a month ago, you can transfer to another agency. But if you're not happy with that second agency,
you have to wait.
Well, you wouldn't have to wait. You would have to revoke your hospice benefit, which means I'm discontinuing hospice. I'm stopping, which ends the benefit period. Let's say on day 45, mm-hmm. and then you can be picked up again, but you'll be in benefit period number 2 or 3, whatever the subsequent benefit period is next. That's the one that you would be into.
Will you describe briefly the difference between dying on hospice and dying not on hospice, logistically, with regards to police? What work you guys do in terms of contacting the coroner, the nearest fire station, etc.?
Yeah. Great question, Brian.
Thank you.
So when you're on hospice and someone passes, because they're on hospice, that is the expected outcome. So when we come in, once that occurs, we contact the medical examiner for that particular county, whether it be Collin County, Rockwall, Dallas, Denton. And because they're on hospice, we give them information, admitting diagnosis. Do they have any communicable diseases? Have they had any falls and medications in order? Is there any signs of abuse, neglect, exploitation? No. They give us a release, and then we contact the funeral home. Funeral home comes out, takes them into their care. It's a very smooth and
dignified
mm-hmm. process.
Yeah.
If someone is not on hospice, well, now you have to call 911. 911 comes out. If you don't have a DNR, which most hospice agencies should be helping you get a DNR in place, which again is a do not resuscitate. 911 comes out. They're possibly jumping on his or her chest. Ambulance is out. They're shuffling them off to the nearest emergency room. Once they get to the emergency room, they're going to get every kind of treatment they can get to try to sustain their life. And then inevitably they die. Mm-hmm. And so now you've put your loved one through all that extra stress, pain. It's just not a dignified way for someone who has lived 60, 70, 80, 90, 100 years. That's not how you would want them to transition.
Yeah, it's tough to see.
And you've traumatized the family.
Yeah, it's not pretty.
And that's a real thing, Brian, I'm sorry. But a lot of this conversation has been focused on, patient, hospice, oncology, social worker. Hospice is it's all inclusive. It's not just, we're not just here for the patient. We're here for the family members. Like once a patient passes, we do bereavement for 12 months. We're reaching out to them. Hey, do you need a grieving a group that's in your area? Do you need our chaplain to come out? Do you need someone to talk to? Do you need a book to read? Like, what do you need to try to help with that process? But when someone is on hospice, that the level of grieving is a little lower because they've been educated on what to expect. It's not a sudden thing. Yeah. It's not like you're driving out here on 635 and all of a sudden, horrible accident, someone dies. That's tough. This is, hey, there are steps that will lead up to this process.
Yeah.
So
deep, you guys. Aqua, what haven't I asked you that I should?
Well, this has been a great discussion. And I think we've really covered some important topics that people can benefit from. But the biggest thing for me is that, hospice is not a bad or negative thing. It's really something that has been put in place so that you, your loved one, and surrounding families can feel supported, loved, resourced, so that that individual can either remain at home or in their assisted living setting or in residential care homes. There's some great ones. Manchester Care Homes has some great residential care homes here in this area. Hospice is not a negative. It's a positive, and that's the biggest difference. The first question you asked me is, what's the difference between hospice now, hospice then? Yeah. Hospice then, it was all bad. Hospice now, it's not all bad. It's actually all good.
It has such a pejorative connotation when in fact it's just the opposite.
Yeah, it's very nuanced.
Thank you. Rochelle, what haven't I asked you that I should?
I don't know if you haven't asked me, but I think my overall point that I'd like to make in closing is that I think I would like for patients and families to realize that hospice is a good thing for them sooner than later. I work with a whole team of social workers, and we are always having this discussion about how it would be so nice once the patient is not receiving treatment, it is the perfect time to introduce hospice, at least have the discussion, so that they know what benefits are available. They're going to get a lot more than they're going to get with home health. They think home health is going to come in. They come in 1 or 2 times a week for an hour a day. The patient is obviously declining. And so are they really going to benefit from physical therapy? Right. Probably not.
Home health, I think we should define as home health is PT, OT,
speech therapy.
Right.
Yes. Physical occupational speech therapy.
Which is essentially continuing to seek treatment on
it's rehabilitation. Right. Yeah. So we're trying to help them end well. We want the patients and the families to end well, and we want them to have all the support that they need.
Beautiful. Awesome.
And I don't know if we're close to closing or not, but I would want to tell the people, if you can get a knowledgeable, resourceful social worker as a part of your care team, that will make all the difference. It literally is like trying to drive around without a GPS. We all have maps in our phones and on our cars. We use those to get from A to B. Without that social worker, you're driving blind. So her role is vital.
As with everything, use your resources.
Yes.
Use your resources. Thank you both. Thank you both very much. Let's move on to the nugget portion of this episode. This is one of my favorites. I only regret not spending more time on the internet, said no one ever. I think we all need to put our screens down and go look at the blue sky and a few trees. So I thought that was entertaining. All right. This is an opportunity for viewers to get to know both of you in a non-clinical setting. Short answer, start with Aqua and move this way to Rochelle. Aqua, where were you born and raised?
Born in Seattle, Washington, raised in Seattle, Washington, moved here from New Orleans, Louisiana.
Rochelle, where were you born and raised?
I was born and raised in Southgate, Michigan.
Aqua, college and degree.
Degree from the Xavier University of Louisiana in business administration, and also getting my master's degree in healthcare administration from the University of New Orleans.
Smart fellow. Go ahead.
Received my bachelor's and my master's degree from the University of Texas at Arlington.
Nice. Do you have a second language? Middle finger does not count. Do you have a second language?
I do not. I'm sorry.
Okay. Do you play a musical instrument?
I do not.
Rochelle?
No.
Still in touch with childhood friends?
Yes.
Rochelle?
Yes.
Spicy food or plain Jane?
Spicy. Jerk.
Mixture.
Mixture. Call or text?
Call.
Dream job as a child?
Pilot.
Nurse.
We're close. Ever broken a bone?
No.
Yes.
All right. Favorite ice cream flavor?
Cookie dough. Bluebell.
Rochelle?
Vanilla.
Can you change a tire?
All 4.
Can you change a tire?
Only if I have to.
iPhone or Android?
iPhone.
There you go. Are you sentimental?
No.
To a fault.
Wow, opposites. Karaoke, yes or no?
Heck no.
No.
Favorite band?
Does Lenny Kravitz count?
Yeah, sure. Why
Heck
not?
yeah.
Lenny Kravitz. All day
Rochelle?
long.
He's awesome.
Oh yeah.
Dave Matthews fan.
Thank you. Do you believe in aliens?
I don't think we're the only people here in the solar system.
Rochelle?
Ditto.
Very well. What is the most gratifying part of your job?
Being with a family that can laugh and smile when their loved one transitions. It's that our job is done well when a family can actually celebrate the life and not actually think about, hey, I'm not going to have this person here with me anymore.
I love that. So, Rochelle, what's the most gratifying part of your job?
There's so many. Probably just being able to be there for families and be a source of comfort for them and education for them when, like you said, they're trying to navigate a system that they are completely unaware of, and just seeing the relief in their face when they know that they're not alone.
This has been very enlightening, educational. I love having you guys. I love working with both of you. I think y'all are both amazing at what you do, and it's an honor to serve the community with both of you. So thank you. In closing, thank you for watching the Manchester Living Podcast today. This episode and past episodes can be seen on YouTube, Facebook, Spotify, and Instagram as well. So please click, please follow, please subscribe. And if there's ever anything I can do for you, don't hesitate to reach out directly. I will put my contact information up on the screen as well as my guests today. Thanks for watching.